All right, thank you for that introduction, Norm. So yeah, I'm very lucky enough to have the role as one of the youth mentors for the Transition Support Service here at the Royal Children's Hospital. So I'm just going to set the scene for the first couple of slides. So transition is the purposeful, planned movement of adolescents and young people with chronic physical and medical conditions from child-centred to adult-oriented healthcare systems. So the little picture you see is sometimes a bit of an emotion that young people feel walking off the plank into the unknown. And still setting the scene, these are some comments that some young people and parents and families, some of the feelings that they've felt when it comes to transition. So this is really what we're trying to identify and trying to fix and address. So I feel like when I get transferred, I'm going to get drowned in the middle of the ocean with nobody around. I'm really sad and nervous about moving to a new hospital. The Royal Children's has been my life. At school, they start preparing you at 15. We didn't feel like we were alone. But at the hospital, it was just like, it's time to go, nice knowing you, good luck, see you later. I felt really lost. So this is what we're working towards. So we're just, these are our outcomes that we're hoping to establish. So I'll just talk you through these three basic elements. So transition planning. So early identification is a huge thing. So if we can ultimately start working with young people from about the age of 15, that's really where we want to start. Earlier if possible, but 15 is a really good age. And so from there, we want to start having that discussion about transition quite early. So the idea doesn't come as a shock by the time that they're 18 and in year 12. So we want to develop a clear plan going forward, and we want to have that coordinated plan. So to enable this coordinated plan, we need to engage parent and family. As well as shared accountability, there's education involved and tailored care. So each young person is going to be different. No transition is the same, so that's why it needs to be tailored to these young people. So education around parents and family and young person. So that might involve a bit of a re-education session for that young person about their health condition, as well as that transfer of knowledge from parents and family to young person to empower them to take control of their healthcare into the future. So it is a shared accountability. And the transfer pathway. So with this early planning, education, starting from an early age, the process and plan becomes a lot clearer. And so by the time that they're over the next couple of years, from 10, 11, 12, there is a process, there is a pathway, and they know what's happening. All right. So this is the key elements of our support service. And our first one is engaging adolescent patients in developmentally appropriate care. This is a big one, and this is where we kind of start talking about, talking to adolescents as adolescents and not as children. And also talking about, age-appropriate care, starting to look at adolescent health issues, allowing these young people to have access to resources to do with adolescent health and education, and so making sure that these resources are available to them. So things like contraception, alcohol, drugs, for having those talks, and they're able to access resources that are specific to their health condition. They're getting this general information at school, sex education, but is it specific to their health condition, and do they have the right information at that age? And so also identifying vulnerable patients. And this goes a lot with mental health as well, so identifying if there is some deeper issues of anxiety, and also if they do need to be linked into other support. So it is quite common for young people to be very anxious about transfer, as well as parents. So that's why we want to instigate those supports early. And when I'm talking about screening, we do this, I'll show you our resources, how we kind of identify if patients are at risk. And, adolescents, there is those issues of depression, self-harm, and other adolescent risky behaviours. So we'll when we do our health skills checklist, we'll ask them, you'll see when I show you the resource that we use, identifying these at-risk patients, and if we do need to link them in with more supports. Developing patient knowledge and capacity to self-care. So sometimes if a young person has had a chronic illness and been a patient at the Children's for 18 years, they can get a bit, I guess, complacent if their health has been really well managed and they've been really well themselves. So sometimes young people, for example, you go, can you tell me a little bit about your health condition? They go, I've got cystic fibrosis. And you go, can you tell me a bit about cystic fibrosis? They'll have no idea. And that's just because they were diagnosed at a really early age. Mum and dad have taken on all that knowledge. And the young person's just gone to clinic and they know they've got CF, they know their limitations, but they haven't had that education that they need. So that's with lots of conditions, quite common. So that's what we talk about when we need to do a re-education session with these young people. So I talked about addressing high anxiety around transfer and, instigating supports. So like Pip talked earlier about CHIPS, Livewire, and if needed, we can refer to psych if need be. Coordinated transfer. So I'll show you a slide in a minute about different pathways for different medical conditions. But for young people to have that peace of mind that there is a pathway and where they're going actually helps a lot. There's a lot about that. You're addressing that unknown for them. And engagement with departments and adult service and primary care. So it can be quite hard for patients if they're across multiple teams. It's what we kind of call complex patient in the fact that they don't just see one department, they see 5 or 6. So coordinating that transfer is really important because it can get quite, confusing. And the children's, it's a national paediatric centre, so we're very lucky that you're able to have usually most of your healthcare needs taken place here. And then when the time comes for you to move to the adults, sometimes the specialised care that you need in the adults will be needed at a different hospital, so you won't be able to go to the same hospital for all your needs. And that can be quite daunting for patients when they've had all their care at the one place. And so learning and developing the skills to be able to manage going to several different services can be quite hard. These are the general transition challenges that we face in our transition service. So the familiarity of a paediatric setting. So change is hard. Nobody likes change. The future is unknown. And that's probably what's the scariest. So I know for myself, when you've been somewhere for 18 years or however long, that idea of going somewhere new is quite daunting. So communication, transfer of medical information, similar. You've had the same doctor, same cardiologist for 10 years, 15 years, 18 years. And how as adults, very common question is, how will the adults know about my child when they've had such comprehensive care here? How will they know all that history? So that we address that, and it's really reassuring to know that the teams do really comprehensive referral letters, and you're able to request copies of all of those. You're right, and that's something we tell young people as well, to get copies of all their referral letters so they have them themselves. Keep a health record. Coordination of care providers, so like I spoke, if they're going to go to the Royal Melbourne for cardiology, if they're going to go to St Vincent's for something else, coordinating that care, and engagement with new health service. So this is a big one that we try and address quite early. So linking them in with the transition lead, as we call them. There might be a nurse coordinator like Michelle, who spoke earlier. We work directly with Michelle and Bronwyn, the PH nurses. So it's a matter of finding that link, the people in the same role at the Alfred to link the young people into. So giving them their contact details, going to the Alfred and meeting them for the first time. So that they're engaged with the new health service, they know a face or they know who to contact. Practicalities, where to go, how to get there, costs. You know, a new hospital can be very hard to navigate, so we highly recommend going there, you know, scoping it out, going before your appointment, catching the tram, learning the public transport, understanding the costs involved might be a little bit different. I know the clinic that I attend at the Alfred, it's very hard to find. It's an absolute rabbit warren. But, you know, now I know it like the back of my hand, but it takes time and it can be quite daunting on your first day to go to clinic and not know where you're going. Different healthcare systems, availability of services. So like I talked, different services at different hospitals. Even simple things like physio and dentistry might be referred out to community-based and not so much at a central hospital. That can also be a bit of a shock. You might be able to be managed in some terms by your GP for some things. I know that I'll talk about a really good GP is a huge key. Funding differences, so maybe some things, your medications was these are just examples, medications or equipment or stuff was you didn't pay for or was low cost and changes when you go to the adult system. And accountability, who is ultimately responsible. So this is talking about your primary team. If you see multiple teams, who's really in charge? And like I talked about, it is that shared accountability, and the more prepared you are, the better your transition will be. This is just an example of one of the recent projects that we've worked very hard on. So, like I said, we work with 400 young people at the Royal Children's and about 17 different departments. Unfortunately, there's only 3 of us in our team, and I work 2 days a week, and my partner works 2 days a week. So we're not able to see all the patients in the hospital. And so we've started with really condition-specific groups. So like pulmonary hypertension, like heart transplantation, Fontan. And so we've started to set up these processes. And as you can kind of see, the real fantastic thing about this is that we engage them at 15 and we do I'll do a general transition appointment with these young people. And then it's fantastic that the Alfred team comes across and we'll have a joint transfer meeting. And this is, we have a few of these, and you can see, so 6 to 12 months, we'll have another one. And this is for parents and families. So they're meeting the faces of where they're going to go, and the doctors and the nurse coordinators have a really good overview of their health. And so it's a joint transfer clinic, that's what we call. So we'll identify these patients that they are 6 to 12 months post-transfer. And so it's the RCH cardiology team, my team, the Alfred heart transplant teams. They'll bring a doctor, a social worker, and the 2 nurse coordinators over as well. And then once these young people have transferred, they will attend a young person's heart transplant joint clinic transfer day at the Alfred, which is attended by obviously patients and the RCH team who comes across and just, you know, we do a handover meeting in the morning, and then these patients do a tour of the hospital at the Alfred with their families. So they spend the morning learning where bloods is, learning where they go have their echoes, ECGs, and then in the afternoon we have the young person's clinic, and it's fantastic. And that's only been set up in the past 12, 18 months. So like I talked about the different departments that we work with, each department is different. So you'll see the different groups, and you can see that all the different hospitals are different. And for groups like spina bifida, DevMed, neuromuscular, you know, there are so many different centres that they go to, and it can be also, you know, reliant on where they're living as well. So cardiology, the Alfred, Royal Melbourne, Monash Medical Centre, St Vincent's as well for some cases. So setting up these processes. So down the bottom you'll see spina bifida, there's just some photos from a spina bifida transfer day that we had with some young people. Yeah, lots of these initiatives are new, And it's really exciting that we're able to be a part of this. So our service we don't do transition, we facilitate transition, so we're a support service. So in no way is my team responsible for the transfer of a young person to the adult centre. We work with the departments in coordinating that transition. And like it said in the HeartKids book, it's really important to acknowledge that transition is a process. It's not something that happens overnight. So transfer is a part of that process, and it's the end part of the process. This is what we know. Patients who are actively involved in their health and healthcare have better outcomes and incur lower costs. Engagement is not only a question of motivation, but also of knowledge, skills, and confidence. Targeting care and support in recognition of a patient's individual needs and capacities is essential. So something that might be suited for this 16-year-old patient, cardiology patient, is not suitable for this 16-year-old spina bifida patient. And that's why it's really important. And like you asked the question earlier about developmentally and, if there is issues of intellectual disabilities and things like that, that we are targeting them, we are addressing these young people at their capabilities. This is just a few little photos of myself. I don't really. So I'll just give you a little bit of background on myself. I had a cardiac transplant done at the Royal Children's in 1999. Same cardiology team as here, still. And the transplant coordinator who was speaking later is like a second mum to me. My family is in WA. And if she hadn't seen me in a while, she'd come and hunt me down. So I was diagnosed with dilated cardiomyopathy as an infant. I was medicated until I was about 7 years old. This time I was living in the Northern Territory, and I became really unwell at the age of about 6, and were medevaced from. I was living on a place called Groot Island. It's in the Gulf of Carpentaria. It's about an hour and a half from Darwin, or the mainland as we called it, and very isolated. Went to Darwin on a family holiday. Was very unwell with flu, tonsillitis, recurrent infections, and was in heart failure. Was medevaced to Melbourne and was listed for a transplant. I received a transplant 2 days after my 7th birthday. My now almost 15-year-old brother was born 2 weeks later in Melbourne, just down the road at the Royal Women's. So I had a very pregnant mum at the Royal Women's and myself at the Royal Children's, as well as my dad and younger sister here as well. We went on a family holiday at that stage, so no one really knew where we disappeared off to. We just didn't really come back for a while. And my family now lives in Perth. After my transplant, I've been really well, exceptionally well, and recently, about 2 years ago, moved to Melbourne independently. And I'm very lucky enough to have this role here. So looking back to things that helped me, there was no transition support service when I was the patient here. But I was very lucky to have parents that encouraged me to advocate for myself at a very young age. They very much taught me that I had a voice, and I know that when we saw the cardiologist, my mum would be like, "Rebecca, you've got a voice, you can use it. How are you feeling?" And even small things like when we go pathology, I knew that I had to go up to the bloods ladies and give them my Medicare card and say my name. Just small things like that. I would go to the pharmacy with mum to, do my scripts. All these small things definitely helped me prepare so that by the time that I moved into an adult service, I knew how scripts worked. I knew how to go to a doctor and talk about my health. I knew my health condition. I knew my medications back to front. And these are things that my parents started at a very young age, which I didn't know until I look back on it now. And being organised, but I also was taught that I could do whatever I liked and didn't have any limitations. Of course I did, but you know, if there was cross country happening at school, there was no chance that I was getting out of that. I was running it, and yeah, just from an early age, really encouraged to get out there, have a crack. Doesn't work, it's going to be okay. Okay, so that's enough about me. Why youth mentors? So why I love my role so much. So obviously, like I just said, there was no transition support service when I was transitioning. So I can definitely identify where there are some gaps and where I can help address these. So it's a really unique role. I'm very lucky to have this job. It's a peer perspective. I'm in no way positioned as a healthcare expert. However, I have the ability to, I guess, have that peer perspective with young people and understand where they're coming from, and therefore build that relationship and rapport with these young people so that if they do have questions about their health, especially when it comes to adolescent health issues, it can be quite hard if you've had the same cardiologist for 18 years and you don't know how to talk about contraception or things like that. And these adolescent health issues, I believe, should be proactive and not reactive. I don't want a young 18-year-old girl crying in front of me because no one's had these conversations with her. But I can definitely be that link. And I'll show you Tim in a minute, and he does the same role as me. So individual holistic approach to all patients. So you saw that we see a varied range of young people with chronic health conditions. And although our conditions might not be the same, there's lots of similarities. And I guess that's where we can really relate with young people about the fact that, you know, medications, appointments, routine, checkups, all those kind of things. You know, when you're unwell, if you get a cold, it doesn't take you 2 days to recover, it might take you a week. Lots of those shared things about having a chronic health condition. And I guess I really, like I said, I want to empower young people to take ownership of their health. And I don't want them to feel like it's something they have to hide, or it's a burden, or it, you know, makes them feel uncomfortable. It's I want them to feel empowered and be motivated by it to do the things that they want to do and not let it stand in the way. So that's Tim. Tim has severe haemophilia A, which means he wasn't born with any blood clotting factor. So he self-injects blood clotting factor once a week. So from early on, he's learned to self-inject. And it's really nice to have that male-female perspective as well in our team. And this is just some really lovely comments from some young people. Thank you so much. It's actually nice to know that someone understands the stress of these years. Don't be surprised if I send an email one day just freaking out about exams or something. And that's another thing. It's important to acknowledge that these young people are trying to complete high school, usually putting quite high expectations upon themselves. We're trying to manage their health as well. It's hard enough for any young person to do year 11 and 12. If you add a chronic health condition on top of that, it can be quite a journey. These are our top 10 tips. I know some of them look really simple, but be organised. So this is really coming down to engaging young people with organisational skills. So if your young person uses their iPhone or their smartphone like no tomorrow, let's utilise technology to help empower young people to build the skills to manage their health. So as soon as those letters are coming in the mail for their appointments, chucking them straight into their phone, sending a calendar reminder, and you can do that between parents, but it has to be something actively that they do. So getting it as soon as it comes, so you're building that routine. So every hospital letter that comes in the mail, that young person knows, I've got to put it in my phone. I've got to put it in my school diary, whatever they use. And also having a health record. So all those letters that come to parents, when they go into the adults, those letters will go to them. And so building a health record, lots of young people don't know where mum and dad keep those letters. They'll go, in a drawer in the study or something. So they know that they're in the house somewhere. So be organised. Adult services are different. Know how to navigate in the new system. So not sugarcoating it. This is a paediatric hospital. You are going to go to an adult hospital. There is going to be a level of expectation that you as a young person know your health condition, you know your medications, and we don't want them to look silly, so that's a big thing. And to know how to navigate. So like I talked, catching the tram to the new hospital, go have bloods or there a week before your appointment, learn where the clinic is, know how to get your way around. You don't want to be an hour late to first clinic at the adults. That's not a good idea. Know your health condition, medications, like I said, high expectation of the adults, that you do know your health history. Again, utilise technology. This is something that we do with our young people. A little dot point history in your phone, date of diagnosis, any surgeries, any other conditions, list of medications. Keep it in your wallet, keep it in your phone. The more they repeat it, it'll become ingrained. Have a good GP, especially recommended for females. Even telling young people that they can see a GP by themselves is quite a shock. They didn't know that. And seeing a GP of their choice is also a big thing. Okay, quickly getting through this. Okay to ask for help. Sometimes young people can be a bit of a trooper. They don't want to look like they're special. Know how to advocate for yourself. Empowering young people to speak up for themselves, talk about their health correctly. If they're unwell, if they need help with things like school special considerations, special for exams, things like that, making sure that they do utilise those supports. Like I talked about earlier, correspondence, letters, get to know your new healthcare team, that link, that nurse coordinator. Are they linked into the right supports? Do they need extra support with CHIPS, Livewire, cycles, psych support? This is a pilot study that we did with young people from, I think it was cardiology, rheumatology, immunology. And just, young person fills scripts, 55% pre, 90% post. Oh, sorry. Yes, 90% post. Sees GP of their choice, knows what to expect. And I know things like scripts sound really, has own Medicare card is on there. No, it's not. I thought it was. Having their own Medicare card. Young people can have their own Medicare card from the age of 15. They can have their own, or they can have a copy of their parent carers. It's a small step towards independence. Keep it in there. It's another form of ID. It's just another form of empowering young people. Might sound really, small to parents, but it allows them to go see a GP by themselves if they wish. And this is the parents. Big one. Reminding child to take his or her medications pre, 83.3%, post, 40%. That's a 50% reduction. And I know that my parents live in a different state, and when I go home for Christmas, Mum will go, Rebecca, have you taken your tablets? So, it doesn't stop, and that's okay. That's okay. But it is important to know that my mum has the confidence in me that I am taking my medications. So that all that hard work that she's done, my parents have done, I should say my dad as well, but what they have done, that I am still continuing that. Non-compliance is a big issue that we deal with in adolescence. That's another issue that we focus on. Not really going to touch on that, but just so you know, we do address that stage of non-compliance when it comes to medications as well. I'll fly through this. Just because you're not in the transition program does not mean you cannot benefit from transition support service. These are my top recommendations for you guys. The health skills checklist is what we use for all young people. We do have two. We have one for independent young people. Sorry, I'm rushing this out. One for independent young people, one for dependent young people. So sit down with your young person, go through that checklist. It's front and back. And on the back it says goals. Their goals might be get their own Medicare card, learn how to scripts process, learn their scripts, learn their medication dosages, find out more about special consideration. Some are short-term goals, some are long-term goals. It's a process, okay? We don't expect young people to learn this stuff overnight. We want it to happen over time. Get pumped. This was kindly funded by HeartKids that we've recently published. I brought a pile with me. It's on the website. Take advantage of it. It's specifically for cardiology patients. There's information about Victorian adult centres, but there is some generic info in there as well for interstate people as well. Also, so go onto our website, take advantage, print them off. We have a fact sheet and a brochure for everything. We're not saving trees. But yeah, and that's it. That's my contact details.